Joined our team less than a year ago, so she's been involved in myotonic dystrophy research and clinical care for many, many years in Utah and then on to New York City, and just moved out to the Bay Area in 2015. So we're very excited to have her join us, and it's great to have her team up with Penny to give this talk. So Penny, I think many of you know, so we're in her home territory here, so she's been willing to stand up here and help lead some of the discussion about advocating. I can't imagine a better advocate than Penny. I'm eager to hear their presentation. So without further ado, take it away.
Betty, I feel really honored, to be honest with you. Dr. Day is, to me, he is the top person on this disease. And Dr. Sampson is the other top person. So we have the male and the female A-team, truly. They're just fantastic. I know I'm wasting time, and time is precious, but they are the perfect combination of clinician, researcher, scientist, and I cannot speak highly enough of both of them, in that they've got the whole package, and I really do feel honored being here. I don't feel like an expert. I'm a parent, and I can be a little tenacious when it comes to advocacy for my child. I have a 33-year-old with myotonic dystrophy, and I have her 13-year-old child who my husband and I have adopted and been raising her whole life. So I got kind of thrust into that role. So in terms of the medical aspect of advocacy, healthcare, I say medical interchangeably with healthcare. We want to talk a little bit from the parent perspective first, and then Dr. Sampson will share the physician's perspective. As a parent, when you have someone in your family diagnosed with myotonic dystrophy, it's an immediate. You kind of have to hit the ground running, and it's really, the learning curve can be enormous. For me, it was enormous, and it took a really long time to get up to snuff with all the different components of the disease. As we know, it's extremely variable. Dr. Day's succinct little summary at the beginning I thought was the best that I have heard at any conference. I was like, expand, but it was so clear the way he did that with the photograph and going through every body system. I just thought that was fantastic. So anyway, the things for me as a parent, when I go to any medical appointment or my child goes to the ER or is hospitalized, I go in knowing her baselines. I think knowing a person's baselines is really important. In my situation, Kayleana, that's her name, and sorry if I refer to her because she's a child, is a little different because we have adults, we have people all over the spectrum here, but her baselines tend to run low. Her heart rate, her temperature, her blood pressure, all of those things tend to run well below what is considered normal. And so I have to constantly educate her team and let them know that, because they might be worried about it, or they might think that she doesn't have a fever when I know she does have a fever. So it's really important to know what your baselines are, whether you're the patient or you're the parent or the family advocate for the patient. And even if it's in the file or in the record, a lot of times the doctor or the nurse, the team, they may not look at that information, or they may not note that information, and it can be really important. It's also really important to know what their medications are. For us right now, it's just respiratory stuff, but I know a lot of people are using all different types of medications, so it's really important to know what those are so you can inform people when they don't know. Part of that is because of the variability and because of the extensive nature of the team that we tend to have with this disease, the communication is not always clear. One department may not be communicating to another department or another department. We're getting better because of the technology now. There's so many things that are linked, but you still have to be that liaison between. And all of these are just things that I notice in my child. I know what her normal behavior is. Because she's a child with a congenital form, she has some cognitive issues and some autism-like issues. And I have to be able to interpret her behavior and share that behavior and what her norm is with any particular person on any given day, whether it be in the medical field or even the special education experience. So understanding what she understands, what she doesn't understand, and if she's deviating from her normal is really important. Understanding what her communication is. And as some of us know, we are interpreters often for our family members because their speeches can be impaired, their intelligibility can be affected, their facial affect can be affected. So they can often be misinterpreted by people who aren't familiar with the diagnosis. And we are constantly in that role of saying, nope, she said this, or nope, she meant that. And it's really important when, especially, if you're talking about an adult. For a child, this just comes naturally. The parent advocates for the child. But if you're talking about an adult family member, you also have to do that. So obviously sleep, everybody could raise their hand on that one, I'm sure. And it manifests in a lot of different ways. For us, we finally, I think, have found a sweet spot. But it took a long time between the BiPAP and the different respiratory treatments and having a bed that can be elevated. There's just all kinds of things that have really helped with Kaylee's sleep hygiene. And it's really important to understand not just what the person's needs are, but how to advocate for those needs also when you're talking to medical providers or educational providers if you have a child, because it really impacts everything. Stamina and fatigue being part of the thing. Sleep can impact it, but I think it's also a distinct thing. So I know when she's exhausted. She looks exhausted all the time to everybody, but I know when she's really exhausted. And that's true of all of us. When we have a family member, we go, oh yeah, you're really, really tired right now. Where, normally their normal is tired, but when they're really tired, it's dramatic and it impacts everything. Appetite, diet, all those things. It took us a long time to get to a sweet spot with her nutrition, and we're still tweaking it, but we finally have a little bit of a handle on what diet works to keep her gastrointestinal system working. And everybody who has anybody in their family with this disease knows that's a precious thing. Myotonia, we haven't experienced that so much. Kaylee's only had it in a very mild way, in her toes actually, more than anywhere else, which is odd. But she's hitting the plateau now, and she will probably have more of an onset with that. How your family member responds to pain is really important because their affect is impacted often. Their ability to communicate. It's really important to be able to interpret that stuff for a medical team. And how they respond to illness. Kids particularly have a very difficult time communicating. Kaylee just had a collapsed lung and we didn't know it. And it took advocacy to get to the pulmonologist when we were in the ER for them to identify that. Same with medications. If they're having kind of a wonky response, you need to know that. I'm going too slow, sorry.
Just let me know.
So the people that are on the team, as we all know, the team can be massive. And for an advocate, that can be daunting. And really, really challenging to keep track of all the piece parts. For me, and I added this after the fact, I put you there because I am the #1 person on my child's team. I know all the piece parts. I know all the different components. I know the people who have to communicate with the other people. And they may or may not, or maybe they know, pulmonologist knows the cardiologist, but the cardiologist doesn't know the PM&R doc. Or, you have to understand all those different piece parts and how to link them. And so I think the parent advocate, the family advocate is key to the whole thing kind of working well. And it can be daunting. It really can if you have a huge team, as you can see. And we have every one of these. And we don't need to belabor that. That kind of goes into Dr. Day's succinct presentation about all the different body systems that are affected. And depending on where you are in your onset and progression of the disease, you may or may not need all these. You may just need 1 or 2, or you may need all of them. So in terms of routine care, being the primary advocate for routine care, you have to really know that list, but you also have to know what's ahead. So for cardiology, for example, if your family member needs to be followed every 6 months and have EKGs and echocardiograms and Holter monitors, or if it's annually. or biannually, or I don't know. But you have to be able to ask those questions and know that for a child, it's probably every 6 months, or even an adult, depending on what the doctor says. But it's okay to be very tenacious about that and ask questions. Same with pulmonary care. How often? Who am I seeing? I'm going to see the pulmonologist and the respiratory therapist, or just the respiratory therapist? Should I bring the equipment? Should I just leave the equipment at home? Do I bring the SD card? All of those things are things that you have to keep track of as an advocate. And sleep hygiene, again, I need not say more on that. So knowing what the standard of care is within this diagnosis, I think, is really important. I use the analogy that people look at me like I have 4 heads, because especially in the special education field, there's a few parents here who understand. You may try to explain to people who do not know myotonic muscular dystrophy that your child has all those systems involved that Dr. Day so clearly articulated, and they're like, what? Then you talk about fatigue and you talk about sleep. You really have to understand what the care is for each component so that you can meet the needs at home, you can meet the needs in the clinic, and you can meet the needs in the ER, and hopefully not the hospital, but maybe in the hospital. So in terms of hospitalizations, I'm no expert. Let's put it this way, Kaylee was in the NICU for the first 10 days of her life. Then all she had was ER visits until a year ago. She's been hospitalized twice this year. So we got a little bit of a baptism by immersion. We found it very fortunate that she was here. She was at UC Davis Children's for her first hospitalization. They were outstanding. So she had really excellent care. And it's funny because John and I, when we were taking her to the ER, our network wanted us to go to, I'm not going to say hospital. I said, John, we're going to UC Davis. In case she gets admitted, she needs to be in the children's hospital. And sure enough, she was admitted, and she was admitted to the ICU of the children's hospital. So thankfully, that was the case, because if she had been in network, it would have been a battle to get her out of network to a better level of care. And teaching hospitals are excellent. They really are on their game. They're, I think, more in tune with what's going on in the cutting edge of different treatments and things. And to be honest with you, the doc she had there was excellent. He was willing to call Dr. Day. He talked to Dr. Day at length. And that, you can't replace that, to have the doctor be willing to talk to the one that really knows. So you really need to know if your family member should be in the ICU. I personally advocate for that, and probably will more, just because of the level of care is better. And it takes a little bit of the burden off the parent or the family member, because they have more close care there. In terms of if you have to have a surgery, you probably all heard about anesthesia precautions. There's a great link on the MDF website about that, and any doctor who knows myotonic dystrophy is going to understand what's needed there. I couldn't articulate it, but I could certainly refer someone to the person that can. Respiratory precautions, all of these are components of things that one should know when they're advocating for somebody who's hospitalized. Hi, can you do Q&A at the end? Because we're going to have a time for that. Okay, good. And I'm trying to speed through. So the hospitalization, I was there on the first hospitalization for, I think, 4 solid days, and I wouldn't leave. People are going, you gotta go, you gotta go. No, I couldn't. I knew I couldn't, because I was the link between all those piece parts. And if I left, sure enough, the one thing that needed to be communicated wasn't going to be communicated. So it's really important that a person with myotonic dystrophy who's in the hospital has a family member there who can communicate for them, who can advocate for their needs. And it's also really important to observe everything that's going on, what's going on with the alarms, what's going on with their baselines, their heart rate, their blood pressure, their temperature, their behaviors, all those things that we talked about before. It's also really important to listen, to try to tune in. And if you're like me, it helps to write it down. I'm not a good auditory person, so I like to take notes. It's also important to share your knowledge, because nurses and a lot of medical staff don't know myotonic dystrophy, and they certainly less often know congenital myotonic dystrophy. They hear muscular dystrophy and they just lump it all together often, and that's not a dispersion, it's just they can't know everything about every disease. So you're that link. And And so if you have a team and they're talking to you about something and they're using vernacular you don't understand, it's okay to go, excuse me, in English, please. It's really important to be able to do that. And it's an advocacy skill, and you kind of have to develop a thick skin and be willing to do that. Asking about testing. What test are you, why are you doing that test? Why is it important? What the results were, if it needs to be repeated, and what it means. And repeating yourself. I do that a lot. And for me, the last one, as a parent, I listen to my gut, and it has served me well. There have been many a time when I didn't listen to it, and after the fact went, like when Kaylee had the collapsed lung, I knew that something else was going on. She didn't have her fever. Her O2 levels were normal in the ER. And the doc looked at her. She was singing, playing on her iPad. And they're like, oh, she's good. Let's send her home with medication. And I said, no, where's the pulmonologist? You know? So it's okay to be tenacious about that. If your gut is saying, there's something else here, really important to just say, no. I'm really good at that word. Okay. So also back to the comment about Dr. Day. So when she was hospitalized here, the doc was great that we had. And I said, I want you to talk to Dr. Day. And he knew him from like 20, 30 years ago. I don't know, who knew, right? But he called him and they talked. And sure enough, Dr. Day gave him some information that he needed. And it was excellent. And it really set me at ease that he had done that. The thing that I did, that I learned in the hospital, and I highly recommend this, and I'm going to tell you I stole it from the Reader's Digest. Actually, I did it before, but is to join the team. So if you're in a teaching hospital, they come by every morning with their carts, and they go over the nighttime and what happened with the person, you know, where this thing went wonky or that thing went wonky, or where this thing was great and they improved. And you're the person that was with them all night long. The nurses come and go. And sure enough, there's going to be inaccurate information that's shared at times. So it's really important to be a part of that. And I just learned that. I didn't know that, but I just learned that. And they're open to it, and it's great. And I think they learn from you as the person who's the expert on myotonic dystrophy as well. So it's really important to ask for that consultation with the expert. Hopefully you have an expert on your team, somebody like Dr. Day, if you're fortunate and blessed. And the insurance depends on what you have. That's tedious, and we could go on for a whole conference about how to do that. But moving on.
We'll do that
a different day. Yeah. So if you are unfortunate enough to have to be hospitalized, your family member is, sanitize everything. It's okay to even ask somebody to gown up or mask up. I've done that before. They look at me like I'm crazy. Like, what? Are there precautions in place? It's like, well, yeah, I'm implementing them. There are. For everybody's safety. If you don't know if the person who's hospitalized has something contagious, and they often will anyway if they have symptoms and they're waiting for test results of something that could be like H1N1 or something. But for the sick person, we have a very fragile population, and it's okay. If they're sick and somebody comes in the room, you don't want them getting exposed to something else. Say, put a mask on. My son wanted to bring my, at the time, 3-year-old granddaughter to come see Kaylee, who was so sick. And I said, no, let's wait a few days, just because she's 3, you know. So the rest of this, I can't emphasize enough. If you're ever hospitalized, bring things that are going to make you comfortable. Because as we know, hospitals are not places to get well. I mean, they are. You know what I mean.
No one goes there for vacation.
No. Don't expect to sleep. You'll be woken up every 2 hours. But so having your own pillow, having your child's own pillow, your own pajamas, all those things are, I'm just a person of comfort. I've got heels on, and I'm like, why didn't I wear something flat? All of that is important. And for us, I realized that the discharge planner she was crazy good. She helped us so much with the care at home. She went through the list of all the respiratory equipment. We came home with a boatload of stuff that we were like, how do we use this? And that person got it done for us. So it's really important that you know who that go-to is in the hospital. Nurses are busy. Don't distract them if they're doing blood draws or administering medications, because the last thing you want is for that to go wrong. And you may be helping them, you will be doing most of the care. You really will, it's just how it works. The filing system. She had a lovely one. I use boxes. What can I say? And those of you who have family members, especially children, we are bombarded with paper. It's just an overwhelming thing. We have piles and piles of paper. So I tend to put the really important things in files with very clear notes on them, and the other stuff I just box it up. Because for IEPs, and this is pertinent to some of you, it's important to know that PT, OT, speech therapy, augmentative communication, all of these things are supposed to be provided through the school. Your insurance may or may not provide it, but the school is supposed to. They're required to. So, and this is all the different things that you need to keep track of. So develop for yourself a filing system that works for you. This is a great idea. This is Dr. Sampson's idea, not mine. I think it's fantastic. So we get business cards everywhere we go. Why not? I keep all the contacts in my phone. So if I need to call cardiology or pulmonology when I'm out and about, I call them. One other thing that I've done is I have a list for family members of all the different care providers for Kaylee, so that if something happens to me, they know where to go, because they would be lost. Durable medical equipment, that's its own thing. I can spend a day on that. You probably get a lot of denials. Don't accept them. And ask the RT and the pulmonologist what the cutting edge equipment is, because otherwise you might get saddled with something that's not as good, it's not as effective, and it's okay to say no.
And we've got a breakout session on PT today too.
Oh good, breakout session later on PT. So my husband, being the brilliant man that he is in high tech, he ordered some sensors on eBay. We couldn't get our insurance to pay for them or buy them for the pulse oximeter for nighttime monitoring. And he found them for way cheap on eBay. We just said, well, that's not worth the fight. So, you just kind of have to know which hill to die on and when you're just going to bite the bullet and do something. Use the loan closet, be resourceful. You learn that. Okay. And this is the end of mine. This is just a summary of different things that you can utilize, particularly for children, to get their needs met. All the different places that you can go for all the things that we just discussed. And I'm floored because I didn't even know that this worked or existed, early periodic screening, diagnosis, and treatment, until recently. It's a federal program, and you can get all kinds of things through them. It's amazing. So check it out. And now, Dr. Sampson, thank you for your time. Oh, yes, you do need that.